Hi, my name is Dr. Wendy Vitek. I'm a reproductive endocrinologist and a fertility specialist, and I'm the lead physician in the Syracuse office for Boston IVF. It's my pleasure to share information about egg freezing. It's such an important topic, and it's one I'm quite passionate about helping women and women understand their options. Feel free to send in some questions, but I'm going to start just with some common questions I get asked frequently when I'm seeing patients that are interested in learning more about this option or just at the start of their journey. So why would someone consider freezing their eggs? Well, the most common reason is they anticipate that there's going to be a delay in their timeline to start their family. And that could be for social reasons. It could be that they haven't found a partner. It could be that they have a career that's quite demanding, and they anticipate that the time will be more optimal in the future. There are some situations where there are medical diagnoses that need to be managed before someone can initiate their family, and that can sometimes introduce a delay as well. So generally, egg freezing is for those that like to plan. The reason why it's good to consider freezing eggs if you anticipate a delay in starting your family is that with time and aging, our egg number and quality change. And we have a sense of how the trends are in the population, meaning if we look at hundreds of thousands of women, we have a general sense that our fertility starts to decline in our mid to late 30s, and then there's a more significant drop in our 40s. Some women are surprised to learn that many enter perimenopause in their late 40s and menopause in their 50s. Once we're in that stage of our reproductive lifespan, pregnancy is incredibly hard with our own eggs when we're in perimenopause or menopause. So for those that anticipate there could be a delay that pushes their window for starting their family into their mid to late 30s, certainly if they're anticipating 40s and particularly their later 40s, that is definitely the situation that should make someone pause and consider this option. So one thing about the data, though, is that we have population data, which tells us about large groups of people, which is helpful to give general counseling and trends. But obviously, each woman or patient wants to know, well, what about me? What is my aging trajectory looking like? And that is something that our field has really worked over the past 10 to 20 years to identify some blood markers and ultrasound markers that can help us gauge egg quantity, meaning the number of eggs that are available in a given menstrual cycle that have the opportunity to become a future pregnancy. The main marker for ovarian reserve, or that group or cohort of eggs, is a blood hormone test called anti-Müllerian hormone, and it can be abbreviated AMH. And thankfully, a number of women have participated in research studies and registries that gave us, again, large data sets that give us an idea of how AMH levels look in our 20s, in our 30s, how they decline in our late 30s and become quite low in our 40s. Once they're undetectable, meaning no longer in the bloodstream, if someone's in their late 40s, that may be predicting that they're within 2 years of menopause. So that ovarian reserve marker called AMH, which is a blood test, is a simple starting point to get a sense of where are you at in your reproductive aging. When we get the first level, we can compare it to population data. So if you're 36, we can compare it to what we see in research studies where we have large groups of women who are 36 who have had their AMH checked, and we can tell you what the average and the range is. if we find that your AMH is lower than expected, it can sometimes be upsetting to hear that news, but it doesn't mean that you're without hope or that you're doomed to have an early menopause or experience infertility. But it gives us a starting point for a really important discussion to help you better understand where you're at and where you could be headed. One blood draw, one AMH gives us a snapshot of where you are at this point in time, at this age, again, relative to the population of women. But what helps us even more so is if we can get AMH levels over time. So if somebody is contemplating egg banking, but they don't think they're quite ready to make that commitment, either because of like financial barriers or physical limitations or delays, then it could be helpful to either talk to your OBGYN or a reproductive endocrinologist, because in some cases, a AMH can be checked every 6 months or year, just to give us a sense of what is the change over time. We find that some women have lower than expected AMHs, but they sort of stay there. So their egg number is not rapidly declining over those serial or repetitive AMH checks. Other women are starting high, and then over time, we're seeing a gradual decline. Those two scenarios can help us. If we can figure out which scenario a patient is in, it can help us help her plan when the optimal or right time is for her to move forward with either egg freezing or starting a family. So I talked about one ovarian reserve marker called anti-Müllerian hormone, which is the blood test. There are other tests. One is a little more involved. It's called antral follicle count, AFC, and that involves placing an ultrasound probe or wand in the vagina so that the follicles, which are the area in the egg that, or the area in the ovary that contains the eggs, can be visualized and quantified or counted. Again, we have a sense of what the typical follicle count is based on a woman's age, pulling that experience from like large populations of women, but it's similar to AMH in that it's something that could be checked periodically to see if it's changing. It's just a little bit more involved and slightly invasive because it involves an internal probe, and it has to be done typically through like a doctor's office or a radiology unit that has ultrasound. So the blood test called AMH is a little more accessible and easier, but an antral follicle count can complement that information and provide a little bit more of the picture. So a lot of women are interested in knowing, well, you can tell me my number of eggs based on these ovarian reserve markers, but how can you estimate my egg quality? Well, that is a very challenging and insightful and appropriate question. It's a great question to ask, but it's a challenging one to answer because we don't have a blood test or an imaging test that tells us truly about an individual's egg quality. So again, we tend to rely on population data, meaning we look at like what happens with quality of eggs in large groups of women who are participating in research studies or registries. And again, we tend to see that as our egg number declines, our egg quality also changes. And some of the signs of a change in egg quality are difficulty getting pregnant. It may be that there are eggs being ovulated, but if the quality is poor, they may not be able to create or lead to an embryo. Another sign of lower egg quality is having multiple miscarriages. Most miscarriages are related to having extra or lost chromosome material in the embryo, and that imbalance of genetic information leads to miscarriage. It's one of the most common causes of pregnancy loss, but there are other causes that are medical or structural related to the uterus. Um, so the tests I mentioned, the blood test called anti-Müllerian hormone and the ultrasound that looks at antral follicle count or AFC. Again, they really give us information on number or quantity. We're not able to really estimate egg quality short of looking at a woman's age and what her reproductive history is. If a woman chooses to go forward with egg freezing, the embryologists, our colleagues who work so hard in the lab to support our patients and provide the technical expertise that makes egg freezing possible, they will sometimes be able to look at the eggs under the microscope and give us a subjective or, in their opinion, assessment of the egg quality. But it is, in fact, subjective, and sometimes we're surprised where an egg can look perfect and fertilize and lead to an abnormal embryo. And also sometimes we subjectively feel that the egg looks of poor quality, yet an embryo results and that leads to a healthy baby. So we can give a subjective opinion about the shape and physical appearance of the egg, but it's not something that we should put too much emphasis on because we could be misguided. Really, the best test of the egg quality is to fertilize the egg and make an embryo. And oftentimes, someone who is egg freezing is hoping to delay fertilization until she is at a point where she has a partner or she's ready to select a donor sperm such that her eggs can be fertilized and embryos can be created. Once we have the actual embryo, there's a level of testing called pre-implantation genetic testing for aneuploidy, which is abbreviated PGTA. That test can tell us more about the embryo than we can learn just by looking at the physical structure or appearance under the microscope. By isolating some of the DNA, half of the chromosomes come from the egg, half come from the sperm. That test can tell us if the correct number of chromosomes are present, and that is a powerful marker of egg quality, and I should say embryo quality, because besides age of the woman at the time when she creates eggs or embryos, the best predictor of whether or not an embryo successfully implants is that chromosome information. We're looking for embryos that are called euploid. That means they have the correct number of chromosomes, again, half from the egg and half from the sperm. So a lot of women are interested in this technology, but they're trying to decide when is the right time for me to undergo the process of egg banking, which requires the first couple steps of in vitro fertilization. That involves stimulating the follicles to grow. Naturally, the body typically chooses one follicle to grow and ovulate out of a group of eggs. And by using injections of the reproductive hormones called FSH and LH, that can stimulate multiple eggs to grow in a short period of time over the course of 2 weeks. And then there's a procedure that's done under sedation, which keeps the patient comfortable, and it's quite safe. At that time, the eggs are retrieved using the ultrasound probe and a needle. That needle passes through the vaginal wall into the follicle. We apply some suction, and we're able to aspirate or remove the fluid, and in doing so, the egg. Once the egg is in the lab, that's when our embryologist colleagues can freeze the egg using a technique called vitrification. So the intense part of the process takes a little over 2 weeks to develop the eggs and have the egg retrieval and the freeze. But the question that I started with was about the ideal time. And ideally, egg freezing will be done when we're in our 20s or early 30s. When we're in that age group, we can successfully have at least one future pregnancy, at least 70 to 80% of the time, if we're able to bank 15 to 20 eggs. If we're in our later 30s, we may have to bank more eggs in order to have a similar chance of pregnancy because our egg quality often changes. So if we're in our mid 30s, like 36 to 38, we may want to bank between like 20 and 25 eggs. And if we're over 38, in that 38 to 40 range, we may want to even consider banking more than 25 eggs if it's possible. Now, some women, that's the goal, but if their egg count is low, it can sometimes limit how many eggs can be created in a single IVF. And in that case, if someone has 10 eggs that can develop, they're successfully able to retrieve and freeze 10 eggs. Sometimes they have to consider a second stimulation and egg retrieval to get another 10 eggs, and sometimes even a third egg retrieval to get a sufficient quantity of eggs so that they have a high probability of having at least one live birth from the group of eggs. It has to be individualized. What I just stated is sort of a general guidance, but there's always personalized care. So if you meet with your doctor or provider, they could give you a more specific to you answer about that question about how many eggs should one freeze. But I'm going to take a moment to pause. Please feel free to submit questions. I already have some that I can work with. So I have a question from a patient who's wondering if about the egg quality after the eggs are retrieved. And like I mentioned, we can look subjectively or give our opinion about egg quality, but we really can't say for sure what the future holds for the egg until it gets thawed, fertilized, and an embryo results. And then that embryo can be subjectively graded, and it could also undergo pre-implantation genetic testing for aneuploidy to see if the chromosome numbers are consistent with an embryo that can become an ongoing pregnancy. So great question. I wish I had a better answer, but I think there's a lot of research ongoing to better quantify egg quality. Have another question. I'm 35, my partner's 37. We had fertility testing and everything came back looking good. So glad you're able to get that information because in knowledge there's power. The next part of the question is, should we have concerns about those results decreasing significantly? How about 2 years later? So again, this is an example where someone has taken that step, maybe talked to their doctor or provider, asked the questions, got the test results, and they have a sense that things look good for now, and they're wondering, will things change over time? You know, I probably wouldn't wait 2 years to check a 35-year-old woman's egg count. I'd probably want to see her back in a year, have her repeat the AMH or the ultrasound to get the antral follicle count, just to see what kind of trajectory or change we're on. Things change slowly in general for women in their mid 30s, but after we get to 38 and older, our egg count can change more rapidly. And in a woman who's 38, who's not quite ready, I'd maybe say, let's check your AMH in 6 months. Let's not even wait a full year to see where we're at. Now, for a man, if his sperm parameters appear healthy, most likely they will be remain a healthy appearing in 2 years' time. There are some subtle changes that happen in sperm in terms of the amount of sperm and the movement that starts to happen in men when they're in their late 40s and 50s and 60s. We do start to see some decline in the sperm parameters. It's not as dramatic as the eggs. Men typically don't go through like an andropause or a cessation of sperm production and testosterone production. So as long as he remains in good health, doesn't pick up any bad lifestyle habits, his sperm test will likely to be unchanged in 2 years. All right, so the next question is how many embryos do you typically want to freeze in order to have 2 to 3 kids? So that's an interesting question. Some come in with the intent of fertilizing the eggs later, either again because they anticipate having a partner in the future, or they anticipate that they're going to use donor sperm, but they're not quite ready to commit to a donor. Once the eggs are fertilized, the sperm cannot be removed, the DNA cannot be removed, so it sort of commits that egg to that fate. So the question I answered earlier was a little bit about how many eggs you want to freeze. This patient is asking specifically about embryos. So the difference is an egg is unfertilized, an embryo is fertilized. Typically, when we fertilize an egg, we let it develop for 5 to 7 days in the lab. Not all early embryos will progress to the full developed embryo, which is called a blastocyst. That's the stage of development where the embryo is actually ready to implant. That's the point that we would typically freeze embryos ideally. And again, the success of the blast embryo transfer really depends on the age of the woman when she created the embryos. And also, if there was genetic testing, does that testing reveal that the chromosomes are balanced or euploid? So if in the ideal situation, we have euploid embryos, roughly 50% of the time, that euploid embryo will implant and go on to be a live birth. After the second embryo, more women will be pregnant. After the third embryo transfer, even more women will be pregnant. So generally, we would say budget roughly like 2 embryos per live birth. So to have 2 to 3 kids, you would probably want to bank somewhere in the order of 4 to 6 embryos. But again, those would be euploid embryos or untested embryos from a young woman, one that's under age 35 who has a high likelihood in the absence of the data, the genetic testing of having euploid embryos. Sorry if that was a complicated question or answer to that really thoughtful question, but the egg number, we're aiming for roughly 20. The embryo number, we want roughly 2, maybe 3 embryos frozen per desired live birth. Okay, if you test embryos after they have been frozen, will it harm the embryo? That's also a great question. So our technology has advanced so much in the past 20 years that we're able to successfully freeze and thaw eggs with a high recovery rate using a technique called vitrification. And then we can create embryos that can undergo a biopsy that does not damage the future pregnancy tissue. It removes some of the future placenta cells, which are rapidly dividing. Even if we remove 5 to 10, they're rapidly replaced because those cells are in a rapid growth phase. So we're able to biopsy the embryo that forms about 5 to 7 days after the eggs are thawed, fertilized, and that blast embryo emerges. And then we can freeze the embryo. Once we're ready for the pregnancy, we can then thaw the embryo and create a pregnancy. So we're able to freeze and thaw eggs, and we're also able to freeze and thaw embryos that are created from frozen eggs. Okay. When you do a transfer, do you only thaw the one egg that they are transferring, or do they thaw them all and refreeze? So that is, again, the type of question that's really thoughtful and deserves a personalized answer. It really depends on the patient's goals. So let's say a woman who is 36 banks 20 eggs. She could, at a point in the future when she's ready to fertilize, create embryos, and become pregnant, typically we would thaw 6 to 8 eggs at a time with the expectation that we're going to get anywhere from 1 to 3 embryos out of 6 to 8 eggs. We don't have to thaw all 20 of her eggs unless that's her desire. Some patients just want to get their eggs out of storage. And others want to keep some in storage in case there is the rare event of a problem at the time of thaw. We wouldn't want to see the whole group of eggs be subjected to that issue. It's rare, but it can happen. And if someone's gone to all the trouble to bank eggs, we really want to make sure we're careful and optimize the thaw strategy. I've also had some women who shared with me that they were really ready to become a parent. They wanted to proceed with donor sperm because they didn't have a partner at that time, but they also wanted to keep some eggs frozen in case they did meet a partner, and they wanted to have a baby through donor egg to get their family initiated, but they wanted to keep that opportunity open to have embryos with a partner should that arise. So again, it really comes down to the age of the woman when she froze the eggs, what her goals are in terms of like how many embryos does she want to create at this time? How does she feel about having some embryos and some eggs in storage? Maybe we only thaw a small portion just so we test the group and make sure that we don't have any issues that affect all the eggs at one time. And then again, some are thinking like they may want to have pregnancies through different partners, be it a partner they meet in the future, or maybe use some eggs with a donor sperm. So, all right. So the next question is, I'm 36. Am I too old for egg freezing? No, you are not too old. You are the exact age that we would love to see and talk to you about the opportunity. So that would be a great time to make an appointment with either your OBGYN or your REI or your provider so that you could share your concern that you may be too old for egg freezing. And then they could hopefully guide you towards getting some of the testing I mentioned earlier, namely starting with the blood test called AMH. That level can be compared to other women that are 36 to help us get an idea of where you're at in your egg quantity change. And that can be a starting point for that discussion. All right, so the next question is, I'm soon to be 42 in November and have been married for 9 months. Haven't yet conceived. Who do I meet first, an OBGYN or just go to the fertility specialist? Great idea that you're thinking about your care team and how to get the care you need as quickly as possible, given your age. I think it's always good to start with your OBGYN. They can guide you. They can help answer some of your basic questions. They can start initiating some of the testing. And depending on your insurance or your community's practices, you may need a referral. Other communities, you're able to call your OBGYN, make an appointment with them in 3 months, call the REI, the infertility office, and make an appointment with them. Hopefully a little sooner than 3 months, but it's possible that you could be seeing both your doctors or providers at the same, roughly in the same time interval. You'll want to keep your OBGYN informed of what's going on in your care. Your OBGYN has hopefully known you for a while and will be the person that helps make sure that your pregnancy is healthy and that you have a safe delivery and that you recover well postpartum. So we definitely want to keep your OBGYN involved and informed of where you're heading. But with your age being over 40, you could go right to an REI office or infertility office unless you need the referral. All right, another question about conceiving naturally at age 40 and what do I need to do? Well, I'm wondering if this person is able to have tracking of their ovulation. There's a number of methods, apps, biomarkers that can help us determine if we're ovulating. That's always a good place to start if the goal is natural conception. And then some could have a test done to make sure their fallopian tubes and uterus are normal. For natural conception to occur in the body, there needs to be at least one open fallopian tube and generally like a healthy uterine cavity. Um, if this person has access to a partner who has sperm, that's obviously like a key part of natural conception. And if they don't have that, they could, again, talk to their OBGYN and their REI or provider about how do I learn more about donor sperm and decide if that's right for me. All right, the next question is, what is the best time of your cycle to test AMH to ensure accuracy? I've read it's best to test at a certain time of your cycle. Yeah, that's a great question. In our cycle, we have groups of eggs that are coming into development, and most women have about two groups that develop over the course of the 28-day menstrual cycle. So because we always have eggs coming into the pipeline, the AMH is reflective of those eggs. It's not reflecting the egg that's about to ovulate. So we can actually check the AMH anytime in the cycle because we should always have eggs coming into recruitment. And that's what AMH is made by, or the early antral follicles. There is one other blood marker I didn't mention called FSH, follicle stimulating hormone. That's a pituitary hormone created in the control center in the brain that travels through the blood and tells one of the follicles to grow large. And eventually that follicle will hopefully ovulate. That hormone typically has to be checked on cycle day 2 or 3 to be interpreted correctly because it fluctuates quite a bit throughout the menstrual cycle because it's directing that step where the egg is selected for ovulation or for recruitment. So an FSH is cycle dependent, but an AMH can typically be checked at any point in the menstrual cycle. One thing that we've learned through, again, women who've been willing to participate in research, which is so valuable and important to our field, is that those that are on certain types of hormone contraception, it doesn't harm your eggs, it doesn't decrease the number or change the quality of your eggs, but because you're not recruiting eggs to the point of selection and dominant follicle development and ovulation when you're on certain hormone contraceptive methods, it can make your AMH look a little lower than it would if you're not on oral birth control pills. Some women wonder, should I go off the birth control pills to get my AMH rechecked? You could, but if you're using it to manage menstrual symptoms that are undesirable, or you're using it for contraception and you really don't want to be pregnant now, we can just factor that in. It decreases the AMH by about at most like 10 to 20%. So that's something I keep in mind when I'm checking it. I don't feel strongly that a patient has to come off of her contraceptive method to get an accurate assessment of the AMH. The next question is it possible to boost egg quality with supplements at age 42? That is a great question, and I wish that there was a supplement that could reverse age or really boost egg quality. There are some that have a marginal benefit, meaning in some cases, it does appear that there's a modest benefit. Those supplements are typically like CoQ10 or DHEA. So those may help improve egg quality, but that's typically at the time of an IVF cycle, and the benefit is marginal at best. The next question is, how hard is it to change quality of sperm with supplements for low motility and count? Yeah, I think anytime someone's learning that they have low count or motility, which is movement of the sperm, it's advised that they see a urologist who's had training in male infertility. There are a number of medical causes that can lead to low motility and count. And working with a urologist who has that expertise can help uncover either through blood work, physical exam, or sometimes ultrasound. They may be able to pinpoint a factor that's contributing to the sperm changes and give you a directed treatment plan that's targeted to improving the sperm count or motility. In terms of supplements, there are supplements marketed to men that have claims of increasing motility and count, but I can't say that the data are strong. There was an NIH-funded study that looked at this question in over 2,000 men using a special blend or supplement, and unfortunately it didn't show a benefit for count, motility, or morphology, which is shape. The other thing for men with low motility and count is to really take a look at your lifestyle. Sometimes certain lifestyle changes can be recommended, and that can change and improve the parameters as well. What are the chances when getting embryos tested that all of them will be abnormal? That is unfortunately the hardest part of our job. When we work so hard as a team to get you informed, get your care coordinated, get you through an IVF cycle safely and comfortably, and you've done everything and we've done everything, and yet sometimes all the embryos are unusable or abnormal. That is certainly heartbreaking. The rate of abnormal embryos is very much tied to the age of the eggs, either when they're frozen or at the time that like if you're doing fresh IVF where you fertilize the eggs at the time that they're retrieved. So it's when the eggs are harvested or retrieved that predict how likely you are to have an abnormal embryo. When we're in our early 30s, it would be unexpected or rare to have all abnormal embryos. Unfortunately, when we're in our mid 40s, we've certainly seen many cases where despite all of our efforts, all the embryos can be abnormal more commonly when we're in our mid to like between like 42 and 46. A lot of the cycles do result in all abnormal embryos. There's a question, where do you see patients? I'm in Syracuse. Well, hi, I hope to hear from you. I'm at Boston IVF in Syracuse, and our address is Whitewaters Parkway in DeWitt. You could certainly use one of the links in order to schedule a visit if you're interested in meeting. Okay, on to the next question. I'm 34. I did a blood test and ultrasound. Great. She's doing exactly what I had explained earlier. She's sharing that her AMH was 2.5 and her antral follicle count was 8. She's wondering, how does that look compared to the average? And I would say an AMH of 2.5 is very healthy for a 34-year-old. The antral follicle count of 8 is a touch lower. I would expect it to be more like 10 to 15 based on your AMH and your age. But it slightly correlates, but it's probably more that your AMH is predictive. I bet if you stimulated, you would probably make more than 8 eggs, which is what your antral follicle count is predicting. With an AMH of 2.5, I would anticipate more like 10 to 15 eggs. So I think you look pretty good compared to average, and we never hang our hat on one single test result because it's more the overall picture or trend that we're interested in. what can I do to improve my egg quality? Anything nutrition or lifestyle? Again, I think taking care of ourselves through healthy lifestyle choices is very important. It can help us manage the stress of an infertility journey or the stress of undergoing an egg banking cycle, namely getting like good rest at night, making sure we're sleeping. That helps to regulate a number of our hormones, including our reproductive hormones. Making sure that we're getting movements. What's good for our heart is probably good for our ovaries and our fertility. Making sure we're eating high quality foods. Eating ultra processed foods is not ideal for ovulation. Those that eat more processed foods may be less likely to have consistent ovulation, where those who eat a more plant forward or plant-based diet may have more consistent ovulation and higher pregnancy rates. So eating high quality foods and managing stress in our life through outlets that are healthy, trying not to fall into unhealthy coping mechanisms like smoking tobacco, vaping, marijuana, alcohol. So trying to come up with strategies to manage stress in a way that supports your health instead of being a negative. Can you speak to the cost of an egg freezing cycle? So that is a great question for one of our financial coordinators. Each cycle has a unique cost. Some of it's based on your egg reserve parameters. That helps us determine how much medication we need to prescribe in order to optimally stimulate your follicles. So once you have the testing, then we can predict your medication dosing, and that is one part of the cost. The other part of the cost is the actual cycle management, the stimulation monitoring, the egg retrieval, and then the freeze. And then there's one more cost to consider. That's the cost of storage. It can be paid monthly, quarterly, or annually, depending on the center you're working with. And then there could be a cost to thaw the eggs, fertilize, and create embryos down the road. So there's a couple pieces to that cost. It sort of depends on the clinic, the medications. Some have insurance coverage, though it's not as common to have coverage for elective egg banking as it is infertility, but there are some employers who offer that benefit. So I'd recommend that you, again, make an appointment with your doctor or provider, and they could help get you on the path where you can get a solid answer to the question about cost. Oh, great question. How do I find a urologist that specializes in male infertility? So there is a fellowship that a urologist does after their general training called Male Infertility and Sexual Health. So using those search terms like fellowship training for male infertility would help you identify a urologist who's done additional training years in male infertility. There are some urologists who have years of experience. They haven't done the fellowship, but they've been practicing for quite a time before the fellowship was more common. And they may have expertise. And again, by talking to your doctor, your OBGYN or your REI, we generally have a sense of who the urologists are in a community that have that expertise. All right, here's a question. I'm 40 years old and have been with my partner for 12 years, but have been unable to get pregnant. Do you have any suggestions? Well, first, my heart breaks for you. That's such a long time to have hope of becoming pregnant and not being successful. I would strongly encourage you to have an evaluation. I think it's important for you to get to the bottom of this and get some answers. And with that type of longstanding history, we are often able to uncover a cause. So again, starting with your OBGYN, if you don't need a referral, you could also start with a specialist like a reproductive endocrinologist and infertility specialist to try to get the answers you need through the evaluation. The next question is about trying to conceive naturally if you have endometriosis. I've been trying for 2 years and never have been successful. Again, I'm so sorry. That's endometriosis can be such a painful condition, both physically and emotionally, if it's preventing your goal of becoming pregnant. Now, there are women who will conceive with a diagnosis of endometriosis, so it's certainly not hopeless. But if someone knows they have a reproductive condition like endometriosis, like PCOS, like fibroids, or they know the male partner has a condition like he's had cancer treatment, he may have low sperm counts. You don't have to try for a year or two if you have risk factors for infertility. You could, again, ask the questions, advocate for yourself, see your doctors, see your providers, and get the evaluation because it will help you get some answers about how to best support your goal of becoming pregnant when you have a known reproductive condition like endometriosis. Next question, is it true that sometimes the genetic testing of the embryos results in loss of the embryo just from the test itself? That's a great question, and that's something that our embryologists go through very rigorous training to make sure that they're able to safely biopsy the embryo without causing damage. So there's a lot of steps in the training such that the embryologist has the expertise and skill to do the biopsy. The other part of that is generally the cells that are being removed for the biopsy are coming from the area that will become the future placenta. And those cells are rapidly dividing. So even removing 5, they replenish or replicate within a very short interval of time after removal. And it doesn't typically damage the embryo in a way that harms it. And the biopsy's been shown to be safe. It doesn't increase the birth defect rate in embryos that have undergone a biopsy. Here's another question. I recently had an egg retrieval, and although I had a lot of follicles on ultrasound, they had a hard time reaching my ovaries. How does this happen? Also, I do have PCOS, so I'm sorry, that's incredibly frustrating to have a lot of potential, but not be able to get as many eggs as anticipated. There's a couple possibilities. Sometimes we see what appears to be a developing follicle based on the ultrasounds. Sometimes when we aspirate or remove the fluid from the follicle, we find that there's actually not an egg in it. So we don't know for sure that the follicle has the egg until we've actually done the retrieval. There can be some empty follicles. The other thing is some people have just differences in their body type or habitus or their anatomy that make their ovaries sit a little higher in their pelvis or even their abdominal cavity. We place the probe in the vagina and we can pass the needle through the vaginal wall into the ovary. But if the ovary is quite far up in the brim of the pelvis or the abdomen, it can be hard to reach it. So there's sometimes situations where the ovaries are scarred because someone's also had a condition like endometriosis or a ruptured appendix. So there can be some variations in our anatomy that can make completing the retrieval more challenging. So there's a question about do I have to do IUI or IVF? Are we able to give treatments before recommending IUI or IVF? So that's a good question. And generally, if someone has a finding like, let's say your thyroid is abnormal, the function, sometimes correcting a hormone imbalance like a thyroid issue can lead to ovulation. Whereas when the thyroid was off, the ovulation wasn't occurring. So there are some rare diagnoses that we find that the treatment is different than IUI or IVF. But those are typically trying to get you to the point where you're able to ovulate and you previously weren't. Or there's sometimes surgeries that help create or open fallopian tubes that are blocked. Or sometimes the urologist can help a male with low sperm counts and motility take medication or have a surgery to improve sperm counts. So there are some times that we can pick a path that really restores sort of natural fertility. But more often, things are in working order. The woman's ovulating. She has a fallopian tube that's open. She has a normal uterine cavity. Her partner has adequate sperm, but they're still not getting pregnant. If that is the finding on the evaluation, then generally the recommended treatment would be IUI or IVF. But I would definitely encourage you to have a visit with your care team and try to figure out if you qualify for one of those more targeted treatments. But they're not dismissing you if they say that IUI or IVF is best, because that is ultimately the most powerful like fertility tools we have at this time. All right, I have what may be our final question. I want to keep my IUD in for as long as possible due to painful periods. Would I be able to keep my IUD in until the actual egg retrieval? Yes, that's a great question. Thank you for asking that. You do not have to have your IUD removed in order to stimulate your eggs or retrieve them. The process of retrieving them would typically not pull out the IUD, and the hormones from the Mirena IUD, which are progestin based, don't negatively affect the ability of the ovaries to make the eggs in response to ovarian stimulation or the quality of the eggs. We learned this when we had women who wanted to donate eggs to help women who have poor egg quality or advanced age. We can stimulate a donor and get the same number of eggs that we would anticipate. And we find that that's true for women who are doing elective egg banking. They can stimulate with the IUD in place. How long can eggs be frozen? That's a great question. Elective egg banking became no longer experimental in 2012. So we've had this technology available to us for 13 years. Some have had eggs frozen for even longer. They were maybe part of the early research. When we use a technique like vitrification, it removes the water from the egg so that when it's frozen, it doesn't have ice, which is what breaks down the cell. So the vitrification technique allows the egg to be frozen indefinitely. So eggs can be frozen months, years, even decades, and still be successfully thawed and create embryos. Embryo freezing has been around much longer, upwards of the late 80s. So there was even a story recently of an embryo that was frozen for 30 years that was thawed and resulted in a pregnancy. That technique is a little bit different. It's called slow freezing, that was used at that time. But nonetheless, it just sort of illustrates the point that we can preserve gametes or embryos for an unlimited or unknown amount of time. All right, I have a question. I froze eggs 5 years ago at age 36, and now I'm ready to conceive. Should I use my eggs or try at home first? That is a great question, because you may find that your 36-year-old eggs have less risk of creating abnormal embryos that could result in miscarriage, or a baby with a chromosome issue like Down syndrome. So if you're very risk adverse, you put the time in, you bank the eggs, you may want to use the eggs to reduce your risk of having like an undesired outcome like miscarriage. But some women try to conceive naturally, and if they are successful, great. If they want to have a second or third pregnancy into their mid to late 40s, that would be a time where really their only option is either using their frozen eggs or an egg donor. So I recommend that you meet with your provider to get a more individualized assessment to that question you're asking, which is a good one. Okay, final question. Why do some doctors put you on progesterone prior to starting IVF meds 2 weeks prior to egg retrieval? So there's an oral progesterone pill called medroxyprogesterone acetate. It's sometimes abbreviated MPA. When a woman takes that medication daily, it decreases her drive to make eggs. It decreases her FSH and LH, so it prevents her from ovulating. So we can use that to sort of quiet the natural selection of the dominant follicle and ovulation that would happen in the menstrual cycle where one of the eggs is chosen. And then by layering on the stimulating hormone injections like FSH and LH, you can stimulate 10, 15, 20 eggs, but avoid having the woman ovulate before she's undergone the egg retrieval. So the medications that can prevent premature ovulation before the egg retrieval are oral medications like progesterone, medroxyprogesterone acetate, or MPA. Another one is an injection called ganirelix or cetrotide. They're in a group of meds called GnRH antagonists. And then a third medication called Lupron. When it's used in a special dose and formulation, it can prevent premature ovulation. So all three of those are options to prevent early ovulation. So yeah, so we're coming up on 8 o'clock almost. So I really appreciate all these very thoughtful questions, and I hope that you took something away that empowers you and helps you make the right decision for you. I just want to reiterate, like, your team at Boston IVF is happy to see you, help you get information, help you get the tests you need so that you can make the decision that's right for you. Have a good night. Thank you.